Good evening, everyone. My name is Carver. I am a clinical application specialist here at Oculus. Welcome to tonight's clinical webcast, Modern Management of Keratoconus with the OCULUS Pentacam. You have a text box where you can enter questions. Feel free to enter your questions at any time, and we will discuss them at the end of tonight's presentation. Tonight's presentation is being recorded, so if you miss anything, you will receive an email copy of it. Our speaker tonight is Dr. Clark Chang. Dr. Chang is the Director of Specialty Lenses and Cornea Department in Wills Eye Hospital, located in Philadelphia, USA. He is the host of the popular podcast show, Chang Reaction. He has over a decade of research experience in corneal cross-linking and other advanced corneal treatments. In recent years, he has been honored with the Top Doctor of 2020 by the National Keratoconus Foundation, the 2021 Luminary Award for Distinguished Practice by the American Optometric Association, World's Top 100 Doctors in 2022, and the Tommy Pham GPLI Keratoconus Practitioner of the Year Award in 2023. We are honored to have Dr. Clark Chang share with us how to manage keratoconus, and I am looking forward to learning from him. Welcome, Dr. Clark Chang.
Thank you. Thank you, Carver, for that introduction. Thank you, everybody, for joining me tonight for this event. So I've got a lot of content here. I'm just going to get into the presentation. Here's my disclosure. And so I thought we start by maybe addressing some of the, not necessarily elephant in the room, but I feel like it's worth delving into, investigating whether or not conventional clinical wisdom and definition of us, of keratoconus is really serving us and as well as serving our patients. I figure that's like a neat angle to start out the lecture, since all of us have obviously been bombarded with different different content. So that's entertain. That's humor me for a second. Let me stay on what seemingly is there may be a somewhat of a elementary discussion, and that is what is our longstanding definition of keratoconus. I mean, when you hear keratoconus, you think, oh yeah, visual impairment, right? Different range of reduced vision, likely some sort of steepening, which can be reflected by your tomography, topography, or keratometry, and thereby would have some form of irregularity, some sort of thinning. Maybe, or at least, relatively young patients is what we usually think. And, depending on the management throughout their lifetime, the chances of requiring a corneal transplant can be high, albeit, a little bit better with some of the, that prospect has gotten a little bit better with some of the technology advancements, both in contact lenses as well as in corneal stabilization procedures. So, but how has that definition, where has it gotten us, where has it gotten our patients? So first of all, let's look at the vision, right? We used to think, well, if it's a disease that impacts the vision, then all that we need to do is safeguard patients' best corrective visual acuity. And ultimately, that's what our patients should be really grateful to us, in that we're able to visually rehabilitate them, regardless of what stage their progressive disease can be or can take them. So if we look through some of the, is that true? If we look at some of the medical literatures that has been around, even as as far back as in Kleck studies, and I'm sure even before that, but they have pointed to the fact that the impact of the disease is very underestimated. It can impact the patient in a very detrimental way, even before there's reduced vision. And therefore, the impact cannot be properly reflected in most of the clinical measurements, such as visual acuity. And even in Kleck's study, which I've have the headings of the publications copy and pasted here for you to reference. And even in Kleck study, where they followed 1,200 I believe 9 or 1,208 patients across almost nearly an 8-year lifespan. Majority of those patients were wearing corneal GP and other contact lenses, and still reported through questionnaires that the visual related quality of life continues to decline despite wearing quote unquote the best fitting contact lenses, right? And also, if you look at the top publication that I had quoted for you, with a very recent one that was published in Cornea back in May, just last month, May 2023. It actually compared or reported the impact of keratoconus to the mental health impact of keratoconus is more severe than that of macular degeneration that we actually knew from CLEC study, but also compared to glaucoma, compared to diabetic edema, compared to vein occlusion. So, again, I bet that we really didn't think that the impact of keratoconus can be that extensive, right? And so that's number one. And number two, so maybe vision isn't all that, it is a very important factor, but maybe not the be all and end all for our keratoconus patients. So let me show you an example that has haunted me actually. So early on in my career, this is a patient that came in. I was doing my clinical fellowship at that time after my residency, and a patient showed up, young patient, going on 18, and self-diagnosed with keratoconus after consulted Dr. Google, and showed up with this presentation. I'm covering up everything because outside of topography and the keratometry values, is because majority of us may only look at that in clinical practice when your patient presents. And you can see that in soft toric lenses, while the patient complains about frequent change in prescription and not fully satisfied with the visual acuity, I was able to, with a new manifest refraction, bring him back to 20/20 in the phoropter. And when I looked at this topography pattern at that time, I was thinking, well, pachymetry is 530 as the thinnest location, so by no means is it thin or extremely thin. And there's no inferior steepening. There's radial skew greater than 20 degrees, and that probably should have alerted me. And also later on, I realized that sort of butterfly pattern or truncated bow tie, which is another risk factor, can be risk factor for keratoconus. But keeping in mind, I was young and innocent at that time. So that didn't really, at that time I thought, yeah, I can't really figure out anything else. Let me have you take a look at the a little bit of take the gestalt of the thinning pattern distribution on the map. We'll talk about that a little bit more. There's a little bit of posterior elevation there, which at that time, as you can see where my cursor is circling, again, at that time, I didn't, I was still looking at the cornea thinking, yeah, this looks quite good. He does have large pupil, and maybe that up to 8 millimeter mesopic pupil size. And so I thought, well, maybe he's getting more spherical aberration from the marginal rays. N9, maybe that's what he's talking about. Or is it potentially maybe dry eye? Schirmer doesn't show that. Is it contact lens warpage? He just removed the contact lens, and the placido disc projection looks slightly, maybe in some places a little bit irregular, but it doesn't, and doesn't look horrible. And the corneal hysteresis, which we took at that time as part of the biomechanical assessment, was 11. So that's greater than 10. Thinking that's probably not, there's not some sort of weakening occurring. So we put him through the ringers of, okay, let's keep watching you very closely every 3 to 6 months. And he's always 20/20, soft 20/20 with any type of contact lenses, corneal GP piggyback lenses, scleral lenses that I fit him with, but never fully satisfied. And sure, 9 months later, you could see there's definitely changes in the topography compared to what I showed you before. Mind you, the central, the thinnest location is still not very thin, proving that one single data point in pachymetry may not always help you diagnose at the early stage of keratoconus disease. But you could also see that the thinning, the location of thinning gets more and more displaced inferiorly. That's a sign. And you could see now the posterior elevation as well as the anterior elevation has become more elevated. That's, again, obviously at that time we were able to say, yep, you know, with the progression, you do have keratoconus, even though I'm still able to keep him in both the manifest refraction and refractor as well as contact lens acuity to be 20/20. Minus a couple letters, we were at that time, okay, able to diagnose him. And remember, this is about 6 to 9 months later. He was already, you know, going into a somewhat, you know, he's seeing therapists because of the depression, despite the fact that I'm keeping his visual acuity in the same line that he presented before, and eventually had to actually use a piggyback because of large pupil so that I could, you know, paint a smaller prosthetic pupil for him and piggyback it with the corneal GP. I really cleaned up the aberrometry. But, you know, the damage, I would say, mentally was done because, you know, he had dropped out of school, didn't want to go to college because he felt really uncomfortable leaving the house. So, you know, so on and so forth. And so just imagine those stories, and I've encountered that kind of stories in patients. They don't always have to be young, but just at the moment of diagnosis and you know, the speed with which you treat them really determines can really determine the prognosis of their outcome. So that tells us that, you know, it's important to diagnose the patient early. And just to kind of close off on before we go into diagnostic technology, I would say that, you know, with the larger pupil patient with irregular cornea, obviously we all know that they're going to get higher amount of high order aberration. So nowadays I will try, at least more and more, I'm utilizing high wave guided optics to help to reduce the you know, high order aberration, the residual high order aberration, such as in this case, utilizing scleral lens, combining it with wave guided optics. And as you can see, because of the larger pupil, and I measure about, again, 8 millimeter, just to kind of two both young patients, white male with similar profile, just to show you how my management strategy has changed, where I, you know, in that other patient after corneal cross-linking, I did a prosthetic piggyback lenses. Now I'm in this patient, I used a high order, a residual high order aberration correcting optics scleral lens that really resolved the visual quality issue of this patient. In this case, you could see the significant reduction in the secondary coma, which is rather unusual. Most of the time, I think primary coma, whether both Z7 and ZA, is more elevated in keratoconus patient. In this case, actually, you know, it's the secondary coma that really affected this patient. And you can see the wavefront maps got cleaned up a lot more after utilizing the treatment approach that I just told you. So coming back to diagnostic capacity and the important lesson of needing to diagnose patients a lot earlier, or as early as we can, rather than relying on our typical slit lamp sign, you know, you know, and I'm not saying that you are not able to diagnose patients using just topography or just slit lamp signs, but remember that those are, you know, those textbook signs are basically an indication of normally a very severe disease stage. So of course, any type of clinical test at that time that's relevant to diagnosing the irregular cornea will give you the same conclusion of cornea being keratoconic. But nowadays, we want to diagnosed a lot earlier. So why are some patients so difficult to catch early on in the emerging phase of their keratoconic journey? Well, for one thing, it's the epithelium, right? The epithelium will remodel, will thin out over the area of protrusion or apex, and so that they could think of it as trying to kind of, you know, maintain the uniformity of the anterior refractive interface, which is your epithelium. To kind of maintain that overall shape as much as possible. So there is a period of time where it is difficult if you're only looking at the anterior corneal metrics. And you know, it is possible. Some have proposed utilizing, you know, OCT, looking at the epithelial mapping, and you could see that it matches here, that sort of donut pattern, which shows you the epithelial thinning over the area apex, corresponds pretty well with the apex on the topography map that I'm showing you. However, I found that that isn't the sensitivity and specificity value, at least with the current technology, is not, in my mind, as high as something like a tomographer such as Pentacam. So I still think that it would likely be, we would have better success using the Scheimpflug image device right at this moment. And I'm not the only one who thinks that. I'll give you a citation of that in a little bit. Maybe possibly if you have, if your OCT can go, white to white. My OCT is not able to do that at Wells Eye Hospital, but Scheimpflug, if the patient can maintain fixation and you have assistance in kind of, opening up the eyelids as the imaging is taking place, some people have proposed that you could actually look at the pair coordinate of superior and inferior mid-peripheral cornea and then be able to better differentiate between pellucid and keratoconus, as I'm showing you here. So I potentially may be able to do that in the future with OCT, but I feel like that's better done at this moment because of the width of coverage. I still think that Scheimpflug camera-based device is better at doing that right now. And so, coming back to, I alluded to the fact that there some sort of consensus in literature that had determined what kind of current available diagnostic tests, what is the best to be able to diagnose keratoconus in all stages, specifically early keratoconus. And here you could see from the 2015 publication of the global consensus paper that had actually concluded that the best available diagnostic test currently is for early keratoconus is tomography, and OCT is included in that. So in the future, possibly combining both type of devices, which I know may be coming, and so that's something that you can keep a watchful eye at this space. But what does it take to diagnose keratoconus, especially if you want it as early as possible? So from this publication, the 3 criteria that they picked was a posterior elevation. Remember, I showed you that in the patient case that we had went through, and also not so much single point pachymetry, but the distribution of the thickness, meaning the relationship of the thinning as it's going from the area of the cone towards the periphery. And hopefully not some sort of inflammatory related secondary thinning to be able to fully diagnose or qualify keratoconus. And so you may say, well, maybe you're at a clinic, you have multiple locations, and one has access to tomography device, but some other location doesn't. So what else can you do before you kind of raise that red flag to say, oh, I need to refer the patient in for further explorative testing or corneal imaging back at my other location? So we could look at things that I told you the patient went through, right? Like refractive changes, keratometric changes. Here's some of the pivotal study that had led to FDA clearance or approval of corneal cross-linking. In a pivotal trial, they utilized cylinder increases of 1 diopter or more within 12, within a certain period of time. Some studies says 12. The pivotal study in US says within 24 months, meaning anytime within, so over 3 months or over 6 months or over 12, as long as it's within that 24 months period of time. They also, with the same time frame, you use the criteria of myopic shift, right, of half a diopter or greater. And you may be looking at these metrics and thinking, well, that's a very small amount. Well, you're right, because we want to catch, if the goal is to catch progression as early as possible, so we have time to discuss with the patient with regard to proper management option, then we don't want to wait for Kmax or keratometry increase for 3-4 diopters before you start your diagnostic journey for the patient, right? So is there frequent changes in the spectacle refraction by record, whether it's someone else's record or coming into you or looking into your prior exam record with the same patient? Is there some sort of asymmetry? And this may rely on a topography if you have a symmetry of IS value, or is there are you consistently getting some sort of error processing in your automated device like your autorefractor, despite patient maintaining good fixation, because that potentially tells you that there's refraction out of range, and that may be suspicious, right? And or patient constantly complaining about quality of vision, even if they can achieve 20/20 line, very similar to the first patient that I showed you, or frankly just, hey, the patient has unexplained loss of best corrected vision at 20/25, 20/30, but remember, in order to diagnose amblyopia, that's a diagnosis of exclusion, and most likely cornea, being the most powerful refractive interface, is going to, in the human optic system, is going to be the likely culprit and must be ruled out first in my mind. So if we're looking past the epithelium, so that beyond just topography, what else can you look at? I already showed you in the patient case the topography map and pachymetry the pachymetry map, as well as anterior and posterior elevation map. There's another display that I find very helpful in the Pentacam called the BAD, or the Belin ABCD display. So what that does is, again, you're looking more at elevation, right? In the, if you could see my cursor, in the left half of the report, and here I have two separate exams, so you could look at either one, but the left half of the page is your anterior elevation and posterior elevation comparison. And so what it does is just shows you whether or not through think of it as like an AI algorithm, if the corneal raw data of elevation, both anterior posterior, is put through an algorithm, a regular cornea doesn't change much. Irregular cornea, such as keratoconic cornea, will all of a sudden have large amount of elevation changes. So if you look at then the bottom two tile maps on the left, on your left hand side, you'll see that the elevation map shows up with either yellow or red. That tells you, hey, this is very suspicious, because a regular cornea, that this should not occur. And remember, we talked about the criteria of looking for posterior elevation abnormality, but also distribution changes in the pachymetry. So if you look at the right-hand side of the display, you could see those two curves called CTSP on the top, or PTI at the very bottom. That's basically the rate of thickening of cornea going outward from your apex, the thinnest area going outward. So that shows you how quickly does the cornea thicken. If it thickens very quickly, not respecting what we think is the regular range of corneal asphericity, that tells you there's probably some sort of central or somewhere central pericentral, there's some sort of thinning. That's why you have the relationship with thickening is so exaggerated. So looking at the distribution is much more helpful. And here you could see, as a keratoconus cornea, both the left eye, becomes more severe, how the graph changes, especially looking at that PTI map. You see the red line that denotes the cornea being measured falls outside of the bookend. So the three dotted lines, which is those are your two standard deviations. So you could see, as the cornea gets more and more suspicious for keratoconus, that red line falls further and further away. And if you find that to be kind of difficult to conceptualize, and you want to look at one single metrics, I think the best combination of sensitivity and specificity is in that final D, which is the capitalized D value at the very bottom left right-hand corner. Here you can see 4.00 for the for when the eye is not so severe, and once it becomes more advanced, you can see it goes up to 16.35. That value can be very helpful. At the very least, tells you that something abnormal is happening. And for those of you with OCT, I get these questions all the time. Well, can we do something with OCT at this time? And maybe that gives me the suspicion of referring for a Pentacam or other corneal imaging. So here's a study from Hashemi, and also just last year, and you could see that it'll be in your handout, or at least you could take a screen capture of this. You could see that while it can be somewhat useful, the specificity and sensitivity value is a lot lower than what I just quoted you from Final D. So I think it's work in progress, but it's not quite there yet with the OCT. And like I said, in the future, maybe combining both technologies can be very helpful. But for now, I certainly still think that shine fluke-based imaging system is more helpful for me. So that just say that we're able to diagnose patient as early as possible for keratoconus, so that we can try to uphold or safeguard the quality of their vision and life by timely treatment and diagnosing them to discuss their prognosis as early as possible, which gives them better prognosis over their lifetime. So how will we determine keratoconus progression then? One thing to diagnose, but another thing to say, okay, how do I determine if you're changing or not? And hopefully as early as possible at that spectrum of change, so that I can recommend some sort of treatment for you to stabilize your cornea. So again, that same global consensus publication said utilize at least 2 of the following parameters, and that is progressive steepening of anterior corneal surface. We're used to doing that with topography as well. But what then we're missing is that progressive steepening of the posterior surface, as well as progressive thinning in the rate of distribution that you and I had talked about with the CTSP and the PTI graph. So how do you do that though? Because again, sometimes hard to conceptualize. Well, I feel like Pentacam had made it really easy for me once they came out with this new tool called ABCD. So A is basically you're in the 3 millimeter zone surrounding the thinnest portion, because the thinnest portion corresponds to the apex of the keratoconic cornea pretty well. So basically we can look for anterior steepening, and B is the posterior, so you could look for posterior steepening, and C is the thinnest location, so that you could compare whether or not at the thinnest location if that amount is changing, because very recently there's actually one insurance carrier that included that. So it may be a trend, but that the one insurance carrier, Humana, actually included a certain amount, I believe it was 10 micron of thinning over 12 months to be a sign, or at least a secondary evidence supporting progression of keratoconus. So you could utilize these values, and D is your distance visual acuity, which obviously is also very important. But if we're drawing on the conclusion or this recommendation from the global consensus, you want to at the very least look at ABC, right? And so you have 3 exam data record here. Yellow is the first, blue bar is the second. I'm sorry, green is the second, blue bar is the third, and spaced apart with some amount of time. This is a patient from Dr. Bir Mekpara, who I work with at Wells Eye Hospital. And the longer the bar, the more progression or steepening we're seeing in A and B. And you could see that hitting that 95% confidence interval, telling me that statistically that's likely a real change that I'm seeing in both category A and category B, whereas the thinning is only hitting about 80% confidence interval in the red gate. And the reason I want to show this example is if we were only following this patient using topography, or only looking at keratometry or Kmax from the first 4 maps in Pentacam and nothing else, you can see that it actually has been pretty stable. Yet using the more sensitive measure of ABCD, I'm able to determine progression that's statistically significant. And the important thing is we like to keep patients' vision the way it is. That's why I'm circling the D value here during across the 3 exams. But let me give you another example of how I utilize this tool just actually a couple weeks ago. So I have a patient who or last month, I apologize. Time really flies when you're in clinic. So, I have a lot of data points here from different dates, and a patient is 39 going on 40, had not been provided any treatment. We've been monitoring him because one eye is already too thin by the time he presented to Wells eye. So we really, at that time, did not be, and also has scarring. It's more the scarring that we didn't feel in the left eye, would qualify for corneal cross-linking. And so been watching the right eye. And presumably most people think, yeah, that's probably at a stage of his life that entering 40, where the rate of progression should slow down. Not that there's no progression possible, but should be very slow. And he seemed to have been stable, at least according to his prior records. So we've been watching him, and you could see that in the blue bar in there's anterior steepening, at least during that one exam. That's substantiated by the fact that posterior steepening seems much more consistent. And the question is, seemingly from 2020 to 2023, if we just look at the PRC, or the posterior steepening, it's been pretty, you could see consistent evidence. But look at it, if I actually, and yet again, looking at Kmax or anterior metrics, that hasn't changed at all, even though there's pretty significant posterior steepening, right? So this is a classic case of a patient who may be underdiagnosed in terms of the amount of progression that the keratoconus cornea is occurring, solely because, using topography and using his age, that may not be enough in this case. But if I reset my baseline to the second exam that he came into Will's eye for, you'll see that if I reestablish, then there's no more progression, then all the subsequent exams didn't show meaningful progression, telling me that either 2019, that's an outlier, even though the quality is okay according to my QS value right here, or possibly the progression occurs sometime in 2019 and has been stabilized since. So we've decided in this case to continue to watch him. So that's another way that I had utilized this tool that I saw was very, very helpful. So ultimately, maybe biomechanical assessment in the future can be very important. And here from publication from Ferreira Mendez et al., you could see that, again, just want to show you the sensitivity and specificity value can be quite high as well, combining tomography findings and biomechanical findings. And hopefully we can have access to this kind of tool in the future in US. So before we talk about management options, I do want to show, and again, for optometrists, this is bread and butter, right? We could restore patients' vision. I hopefully have shown you using literature data that that's not always enough. But for somebody who's not progressing, potentially that could be enough, right? At least most of us think so. If they're not progressing, then being able to, again, elevate or restore their visual quality may be something that most patients will be happy with. And here's a 42-year-old patient, a case from Dr. Jeffrey Sensino. Again, 42, similar to the age profile that I just showed you in the patient case from my clinic. You could see in 5 months, that cornea progressed to the point that the roughly 390 thickness of tear lens is being eroded because of the progression. And this is a 42-year-old patient. So, again, something that's again, just kind of showing us, and we have a lot of these cases in whether anecdotally or in literature, showing you that contact lens is great. It's definitely one of the best tools that we can have to help patients safeguard their vision, but it doesn't take care of progression, right? So what do we do? So, right now, because of the better diagnostics that we have in Pentacam and other devices, we should aim to diagnose patient as early as possible so we could discuss the possibility of stabilizing them so that we can halt or slow down their progression and therefore be able to maintain the best possible vision potential so they have other options. And most of the time that's going to be contact lenses for the rest of their life, right? And that's a happy patient. So when would you think about referring for corneal imaging and other additional testing? Here again, we talked about these kind of low tech, if you would, especially if you had a low tech metrics that you could use, refractive shift, keratometric shift, and visual complaint, visual quality complaints, and family history, that type of thing, eye rubbing, chronic eye rubbing. Those are all things that we need to pay attention to. Now, I mentioned the pivotal trial in US that led to cross-linking, eye-link, corneal cross-linking approval. So what kind of criteria did they use for progression? I already told you it's within any time frame within 24 months when you have increase of at least one diopter in the steepest K or keratometric value, or one diopter in increase in astigmatism, myopic shift of half a diopter. So those are all things that we could utilize, since it's widely used in a lot of different studies. And ultimately, what did it show to get to be able to get FDA approval, which is, blue bar is the group of patients who were treated, and the sort of pink fuchsia color bars are patients who were not. So they continue to, you could see that the untreated group, or the sham group, continue to progress, whereas the treated group, the blue bar group, continue to flatten with an average about 1.6 diopter at 12 months or at 1 year. So that's the difference in the prospect or prognosis in these patients, the difference between treated versus untreated. So this got us the FDA approval since 2016. That is a Glaukos device, who I work for, and I'm in the medical affairs, so I do want to make sure that I do mention that. And so what's approved is a very specific drug device platform with Photrexa viscous, Photrexa if swelling needs to be done for the patients who intraoperatively have a little bit thinner cornea, and also the UV light device called KXL device. Together, they refer to as the eye-link procedure. So what happens during the procedure? It's an epi-off corneal cross-linking protocol. Currently that's the only FDA approved methodology. So remove the epithelium, saturate the cornea with your Photrexa viscous for 30 minutes, one drop every 2 minutes. Make sure that it's fully saturated. And also checking for flare that tells you that excessive riboflavin is seeping into your anterior chamber because you've saturated your stroma. And as long as the patient corneal thickness is greater than 400 at that time, you can proceed with the UV irradiation. If it's thinner than 400, then you use the hypotonic Photrexa. That's the second riboflavin that I told you in the last slide. And every 5 to 10 seconds, one drop until you reach 400 micron or more, and then you could start your UV irradiation. And here's a very neat study from Dr. Galamudi, Dr. Fuller, and Dr. Rashid from SCO, and that is they found that in the group of patients that they needed to use the hypotonic Photrexa, most of them can be done in 10 to 15 minute interval. That's obviously additional treatment time, but the maximum thickening that they found, or the swelling that they were able to achieve, was 161 micron. So the good thing about getting FDA approval is that slowly we're getting better insurance coverage. So you could see that almost every state there's commercial lives that are covered for corneal cross-linking for patients with progressive keratoconus. And you may be asking, and sometimes even patients may come and ask you, why do I really need corneal cross-linking even if I have progressive keratoconus? Because does it actually take away my keratoconus? And the answer is obviously no, right? It's to halt and slow down the progression of keratoconus, and therefore we can't really, you may get some degree of flattening, but you can't always reverse what has been lost, and that's the importance of treating as early as possible. If you look at Academy of Ophthalmology and their preferred practice pattern guideline, it recommends prompt referral as the earliest sign of progression. And I feel like this second part is what doesn't get discussed a whole lot, which is why prompt referral? Because ultimately it's to reduce or stop progression and preserve good visual acuity with glasses or contact lenses, which means that we could do what we do best for our patients. And combining these treatment with contact lens after corneal cross-linking for progressive keratoconus, so that you stabilize their condition. Otherwise, you may have to frequently change their prescription, pending what kind of contact lens design you use, or if they're still wearing glasses. So again, I feel like that point doesn't get discussed enough as to what is really the goal, is to make it easier for you and your patient in your clinic. And if patient still needs further, with progressive keratoconus, patients still need further convincing, look at the health economic data coming out of US that was published in Journal of Medical Economics in 2020. That there's definitely reduction in corneal transplant, which I think we all want to see in for our keratoconus patients. But I think even more importantly, almost 3 decades fewer or less time spent in advanced stage of the disease. Again, that means the patient has better outcome, they have better quality of vision and life, but also less chair time for you to manage a complicated or complex cornea. And better quality of life here demonstrated by these, and these are not the only 2 publications that show that, and certainly feel free to read them and draw your own conclusion about the importance of corneal cross-linking across all stages of keratoconus, as long as they meet that criteria that we discussed under FDA-approved labeling. So ultimately, it's so that, when you combine what the state-of-the-art FDA-approved procedure can do, and with the advancement in our contact lens technology, really can give us patient the best prognosis throughout their lifetime. And, you may also be asking, and your patient may be asking, well, how long can that really last? Is it a year? Is it 2? Because most studies that I read may only follow patients out that far. So if you look at the work from Dr. Greenstein's group, this publication is now has been accepted in eye and contact lenses. I don't know when it's going to be published, but certainly probably pretty soon in the near future. But you could see that in keratoconus group, the best corrected vision is after 10 years, 100% stable, and nearly 90% of keratoconus eyes are stable after 10 years. Now, mind you, it's a small sample size because of the length of the follow-up, and it looks like a little bit, slightly less robust response from ectasia eyes, probably pointing to the fact that the mechanism of action in the corneal architecture, in that sort of biomechanical weakening, is different for ectasia eyes following refractive surgery. But despite that, I would say still, good in 10 years, still good percentage of eyes are stabilized. So it also may be that you don't really want to deal with postoperative recovery with the patient, or the management option may be time that you feel like you don't have. In fact, it's pretty easy, right? It's not that different from, say, a PRK, where you wait for them to epithelialize, that usually within the first 4 to 5 days underneath the bandage lens, and you obviously want to prescribe antibiotic, and also topical antibiotic and topical steroid are the most common. Similarly in post-PRK, topical NSAID, because some people feel like it, interferes with the healing of the epithelium. So some surgeons and some ODs like to use it, and some don't. So it's an optional, and then obviously non-preservative-free artificial tear for lubrication, and possibly oral analgesic. And the most commonly reported from phase 3 pivotal study, most commonly reported adverse event is corneal opacity and haze, that which we'll touch up on in the next slide. But obviously, epi-off, so epithelial defect that needs time to heal, and discomfort and pain and blurring vision. Of course, you're missing the epithelium. So, but you could see the majority of the adverse events resolve very early on in the postoperative follow-up. And so cross-linking associated haze is not always visually significant. And as I can show you here, using Scheimpflug imaging to kind of follow the corneal densitometry reading, if you would, even though I'm not giving you a quantification here, you could see that without intervention, because we stopped the steroid at week 3, and this patient, despite no further intervention, continues to resolve, and that cornea continues to clear up on its own because of the cellular remodeling that was occurring in the wake of increase of biomechanics from epi-off corneal cross-linking. So probably one of the most important question I think that I hear from my colleagues is usually, well, when do I start refitting them? I think as long as usually, a typical recovery course, as long as the epithelium looks well adhered, I think anywhere from 3 to 4 weeks is very reasonable. Obviously, also depends on what type of contact lens. Are you vaulting the cornea, or are you putting more pressure on the cornea? For example, scleral lenses versus corneal GP, that kind of thing. But I typically start my patient, refit my patients or reevaluate their current lens on them sometime between 3 to 4 weeks. And here's a pretty standard follow-up schedule for you to consider. But, and you may ask me, hey, before we talk about other treatment options, what's new? Obviously, if you have progressive keratoconus patients, you shouldn't wait until, generation 2 to get FDA approved. You should give them the hope of stabilizing or slowing down their progression right now. But, we are looking in glaucoma, we are looking at how do we enhance and optimize the effect of corneal cross-linking when we want to maintain the epithelium. So as you can see here, as the oxygen in the video, as the epithelium, as the riboflavin oxidizes during the photochemical reaction of cross-linking, you could see that it becomes darker because now it enters a more stabilized ground state that doesn't want to be excited anymore. So you don't drive any further chemical reaction. You need oxygen to do that. So once you pump in oxygen, you can see the coloration returns. So what does that mean? That means that we need to figure out a way to bypass the epithelium so that we can increase permeability of the riboflavin. But when we did that in literature, you could see the effectivity is not as great when compared to epithelium off. So we figured out that, or at least we think we figured it out, we need to optimize the UV energy level. We also need to optimize oxygen. And you could take a look at the press release at the end of our first phase 3 trial. You could look it up on your own and make your own decision in terms of whether or not this is something that's worth being excited for. We're currently underway with our phase 3, and the enrollment has already stopped because we've gotten the number that we need in terms of the treated eyes. And so hopefully next time when I see you, or sometime in the future, I could share more information with you on our generation 2 corneal cross-linking with epithelium on. And so if we're able to stabilize the patient and then utilize the best contact lenses, probably we could spare a lot of patients from needing further corneal procedure. But you may have patients who couldn't tolerate contact lenses, and now that the progression is out of the way, is there a possibility? Of course, this is not FDA approved in US, but has been done outside the US first coined by Dr. Susan Jacobs from India. And you can see that basically shaping the allogenic graft into something that looks like an intact segment and then insert it into the cornea to achieve a lot of flattening as well as regularization of the corneal surface. And really ultimate goal is that we don't want to have to worry about corneal scarring necessitating corneal transplant in keratoconus patients. And obviously, grafting technique has gotten better, and you don't always have to do penetrating corneal transplant, even though obviously with advancement in therapeutics, we're still getting better outcome. I'm showing you I figure we've all seen surgical videos of penetrating keratoplasty. So this is a DULC. So that's a lamellar keratoplasty where we want to get down to the decimal level and try to strip the stromal tissue, and then therefore at least you don't have that open sky time where the host endothelium is not present. So you inject air bubbles into the anterior chamber and slowly tease out the tissue in various depths to very carefully get to decimate and or get close to decimate, and then I think it's coming up, and then try to open up that very thin area without penetrating. This is called the brave slash, because you want to be very careful not to breach endothelium. You can see that the anterior chamber bubble is still in place as you're after that brave slash, so that you could further dissect the last layer of your tissue before you place the lamellar donor tissue onto the eye. And so let me show you what it looks like if we actually breach the endothelium. So here again, the brave slash, and you see the anterior chamber bubble in the clear portion of the in the peripheral area. Here you see the bubble and the fluid rushes out. So this is a case where we had told the patient there, with your thin cornea, there is a chance that we're going to have to perform penetrating, but we're going to try doing a DULC, a lamellar keratoplasty first, so that we could give us the best chance to maintain the endothelium. But in this case, if the endothelium has been breached, then we will just perform a penetrating keratoplasty. So where does this lead us to? Well, you can see that again, there are plenty of literature in the available to show that after the introduction of corneal cross-linking, the rate of utilization of different type of keratoplasty has dropped. And here is a paper that from France that actually accredited not just the rise of corneal cross-linking, but also improvements in contact lens technology, which I think is correct, that when we could hit the root cause and stop the progression in keratoconus patients and be able to provide them with the best fitting contact lens, should they require. If you catch them early enough that they still have great visual acuity with their spectacle, then even better. But I do believe that both combined together is going to be the best hope that we can offer our progressive keratoconus patients. So that's the end of my presentation. I promised Carver that I would stop, and I think I'm a minute over what I promised. Carver, I'm going to give the microphone back to you.
Perfect. Thank you, Dr. Chang, for that great presentation. I really appreciated your holistic take on the responsibility of doctors to not only treat the patient's disease and quality of vision, but the importance of addressing the impact of keratoconus on their long-term mental health and their financial situation.
Thank you.
All righty. In just a moment, I'm going to ask Dr. Chang the questions you all have submitted during his presentation. On your GoToWebinar screen, there is a text box or a chat box where you can enter in any questions you may have. If you missed part of tonight's webinar, or if there's anything you would like to go back and review, you will receive a link to the recording within the next week. All righty.
And Carver, do I need to exit so that you could show your slide, or should I just?
No, I can take care of that myself in just a moment.
Perfect.
Thank you. Alrighty, and Oculus is currently offering an exciting promotional deal throughout the month of July of 2023. When you purchase a Pentacam or other qualifying piece of equipment, you pay 0% interest for 12 months. To learn more, contact your local sales representative or email sales@oculususa.com. Offer ends July 31st, 2023. Valid US residents only. Terms and conditions apply. All right, with that out of the way, let's hop into the questions. All right, so the first question I have for you is if keratoconus fails to stop, sorry, if cross-linking fails to stop keratoconus progression, is it common to attempt cross-linking again, or are patients usually sent for another procedure?
I mean, it may depend on, at least this in US, it may depend on what type of cross-linking patient actually underwent. As I pointed out, that currently even though we're working, Glaukos is working on getting our next generation Epi-on cross-linking approved, and it's taken this long because we want to improve up on prior Epi-on corneal cross-linking outcomes that have been reported, right? So however, there are study sites that are also doing the same, and I've definitely have patients who actually undergo. We think corneal cross-linking is just one thing, and it's not. If they underwent, say, a trial version of epithelium on cross-linking, and that have failed, and obviously you need some time to determine that say 6 to 12 months have gone by and the patient really has not responded, then in many of the study sites outside of US would actually perform epithelium off, because that ultimately is one that we don't have to worry about bypassing the epithelial tight junction and inability to fully saturate using riboflavin in the stromal tissue. So it may depend on, number one, what type of cross-linking is. When I ask a lot of my colleagues this question, I usually get a blank look and say, I'm not really sure. I just know cross-linking was done. So I would say find out which one. And number two, even if you look at pivotal study or some of the longer term epithelial cross-linking, for example, the 10-year study that I showed you, again, the longer the follow-up duration, the smaller the sample size. That's just the nature of any type of follow-up with patients. For keratoconus eye, they were showing that 89% of patients, if you look at keratometry or topography, they were still stable. And I believe Ray's Cup from France has shown, at least I think he's from France, has shown 15 years and something like 14 to 15% require retreatment, and that's with epi off cross-linking. So they simply just retreated with epithelium off cross-linking again. So yes, it's rare, especially if you think about the fact that it's after 15 years in that report. It's a small portion of eyes being retreated, but it can be done.
And if I remember correctly, that's much better than the rate at which a corneal transplant fails.
That's right.
Alrighty. I'm actually going to make you the presenter again, and I'm going to have you go back to an earlier slide so we can address one of the questions that we have. While I have you doing that, I'm going to ask you one more question.
Okay.
Are there any notable differences in performing patients that have, more traditional keratoconus versus patients with pellucid marginal degeneration?
Yeah, that's a great question. The challenges has been with with PMD or pellucid marginal degeneration is that they've done computational modeling to show again, some studies have actually looked at treating corneal cross-linking by moving the light around. And computational modeling work have shown that possibly if we could direct the energy level to align it with the area, to align with basically the apex, which is very inferior, and you have to protect the limbus if you're going to actually move a circle, say 9mm down, and then move that center of the treatment beam profile towards the 2 millimeter away from limbus usually is where the pellucid thinning is. So there's some concerns about protecting limbal health, and that their computational work that were done to show that may give you best amount of corneal regularization if you could shift where the energy level is being projected to. So there's some challenges there. And that's the reason why actually outside of we're currently looking at what we're calling, maybe think of it as a generation 3, where we could actually customize that light beam profile a little bit better. Although we're thinking for, just low cone keratoconus patient, it potentially could also have a better pellucid application. So certainly that's a possibility as well in the future.
That's really exciting. All right, so if we can kind of go backwards earlier in the presentation, I believe it was the slide just before your list of where you had like the IS ratio, the difference between the two eyes,
Yeah. So that's before this. Hold on, let me
going back a
see
ways.
how quickly I could click my, let's see, it's IS ratio. So here, so it's
Yeah, I
before.
think it's the slide before this. It might actually be the slide before this. Yeah, so I had the question, is the rightmost image on the slide why you can see a double optic section while performing a back, and then it says AB. I believe it's talking about a slit lamp examination in this part. Might be this slide or one of the follow-up slides.
So
If you
not
are,
this slide, but
might be the slide directly after this,
directly after this here.
potentially.
So this is the one with the IS ratio. Which one do you think the question is, or
It might be
maybe
the one directly before this, but that's okay.
the,
If you're still watching, go ahead and clarify that while I ask kind of one other question. So in the slide, you see a distinct irregularity in the astigmatism. You mentioned earlier kind of that 20 degree, the
Mhm.
irregular astigmatism being more than 20 degrees. Is that kind of the cutoff that you use when you look at the irregularity in the astigmatism, or is there some other kind of value that you look at or kind of cutoff that you use?
Yeah. I believe it was Rabinowitz who first proposed it, but it certainly it could be someone else, but I believe it was Rabinowitz who came up with the IS value, and in which he also discussed that radius skew, even if you have some sort of asymmetry, let's say that's more bottom heavy, so that sets up the IS inferior superior asymmetry, but that's not the only sign of suspicion. If you have radial skew greater than 10 degrees is suspicious, greater than 20 is typically regarded as basically a cutoff for abnormal. So anything greater than that, that something is likely needs to be investigated. It obviously doesn't necessarily mean keratoconus, but it means that on the corneal astigmatism wise, not refractive astigmatism, but corneal astigmatism wise, when you have radius skew greater than 20 degree, and then that tells you there's enough asymmetry for you to be suspecting something is occurring to the cornea if it's not a corneal warpage situation due to contact lens wear.
Perfect. Thank you so much. Unfortunately, that is all the time that we have for tonight. For any of the unanswered questions, I'll go ahead and email those over to Clark and we'll try and get those answered. If you have any final follow-up questions, go ahead and email those as well. We're happy to get those answered for you. On that note, thank you all so much to everyone who sent in questions. Thank you everyone for joining us, and thank you so much, Dr. Chang, for your wonderful presentation tonight. Any final words?
No, thank you everyone for joining me tonight, and Carver. I'll see you next time.
Thank you so much. Good night, everyone.